organ transplantation, which is largely, not completely, but it's largely a very good news story. So, in no particular order, we're going to go through lots and lots of things, but we're going to talk a little bit about what organ transplantation is. And I'm really concentrating on what we call solid organ transplantation. So, you know, arguably you could say that blood transfusion is a form of transplantation, so I'm not going to talk about that. I'm not going to talk about bone marrow transplantation. I'm going to talk about transplantation of kidneys and livers and hearts, and one or two other bits and pieces as well. As we go through, there's lots of definitions and terminology. I've limited it to the stuff that's kind of hopefully interesting and relevant for what we need to know. We'll go through some statistics about organ donation, transplants, the kind of stuff that people are having done. I'll then try and sort of talk you very broadly speaking through the process that takes somebody from becoming ill all the way through to them having their transplant and the kind of then monitoring and stuff that they have to have after that. And some of the complications that might arise as a result of having a transplant. And then I'm going to touch very briefly at the end about some specific changes in organ donation legislation, which probably went under a lot of people's radar, and we'll explain why that was as we go through. So broadly going to talk about this, and we'll see where we get to. So it's nice to put something a bit quirky in. So I mean, clearly you'll probably have worked out on the basis of the title of the topic what these people have got in common. Do you know do we know who they all are? So this is Dick Cheney, who was the former American Vice President. You only get a shirt like this if you're Evel Knievel, yeah, a stuntman. And then probably I guess the most instantly recognisable might be this guy, who's Jonah Lomu, who was one of the New Zealand All Blacks. And if it was in a pub quiz, what links these people, and actually quite a few other famous people as well, it's that all of these people have had organ transplants. Okay, so Dick Cheney was a very, very heavy smoker in his earlier life. He was kind of smoking 60 a day. And as a result of that, and of, I presume, some other bits and pieces that I couldn't find on Wikipedia, he had his first heart attack when he was in his late 30s. He had several heart attacks and other cardiovascular problems over subsequent years. By about 2008, he developed significant heart failure. So he was admitted into hospital, had his treatment optimised, and it became apparent that he was probably going to need a transplant. But there wasn't a transplant available immediately, as is usually the case. So he actually had a thing implanted called a left ventricular assist device, which is basically like a little impeller pump that they implant into your chest next to your heart, and it takes over the role of your left ventricle, which is your main cardiac chamber. And that kept him going for about 18 months. And the interesting thing, if people have these, is it's a continual process. So it's propelling blood around all the time, unlike your heart, which does it periodically with beats. And so when you have a left ventricular assist device, you're alive, but you don't have a pulse. Yeah? So you're just continually blood flowing. So he had his assist device kind of in 2008, and then in 2010 he had a heart transplant. And to the best of my knowledge and from what I can understand, he remains well and reasonably fit now. So that's to say he's had a heart transplant. Evel Knievel, unsurprisingly, due to the amount of injuries he had, required a lot of blood transfusions, and he had a lot of blood transfusions in the 1970s and 1980s, before blood was routinely screened for hepatitis viruses. And as a result of having contaminated blood products, he contracted hepatitis C at some point in the 1980s. By the sort of mid-1990s, that hepatitis C had caused chronic inflammation and scarring of his liver. He got liver cirrhosis. And then by the end of the 1990s, his liver had failed. And it's quite an interesting story with a little bit of irony thrown in. So he was admitted into hospital with very severe liver failure, and essentially he was told that without a transplant he only had a few days to live. And he was a pretty pragmatic sort of guy, I guess, who thought, well, I'm not going to get a transplant. And he basically said he wanted to be let go home to spend his last few days at home. And on his way home, he was contacted by the transplant coordinator to say, we've got you a liver. And he had a liver transplant in 1999, and he survived for about 8 years with his liver transplant. And the irony of it is that his liver was donated from a young man who had died in a motorcycle accident. But so Evel Knievel had a liver transplant, and again survived for a reasonable length of time, about 8 years or so. Jonah Lomu, probably, I kind of had to do a bit of research about the others for this, but I knew that Jonah Lomu had a kidney transplant. It was kind of quite widely publicised at the time. So he was in the All Black team that won the World Cup, one of the many times they've won the Rugby World Cup. And shortly after that, he developed a condition called nephrotic syndrome, which is a kind of inflammatory condition of your kidneys. And that fairly rapidly led to advanced kidney failure. He had a period of kidney dialysis, and then he had a kidney transplant. And his transplant, it subsequently transpires, was donated to him by a kind of a famous New Zealand radio disc jockey presenter. But he had a kidney transplant. Unfortunately, I mean, he had his kidney transplant for several years, and then it started to fail. And we're going to talk about what might happen with transplants, but his kidney started to fail. He ended up requiring dialysis treatment again. He'd had it before. And then unfortunately, whilst he was waiting for a further transplant, he died of a heart attack. So kind of different types of transplant with sort of different stories behind them and different outcomes, but fairly typical stories of the kinds of things that people who need a transplant go through. So some terminology, and I've picked out sort of 3 terms which we sort of loosely throw around really. So the first one is this thing called an autograft. So autografting is taking a bit of tissue, so in me, it'd be taking a bit of tissue from one part of me and putting it into a different part of me. Okay, and the commonest recognised example of that would be skin grafting, probably. So they do it with tendons and other things as well, but skin grafting. The skin grafting has been a recognised procedure, surgical option, since the mid-1800s, 1860s, so it's quite an old technique. And like lots of other things, like within surgical fields, it was accelerated by things like the First World War and injuries and stuff as a result of that. But it's a very old technique. But autografting, skin grafts, that kind of stuff is not really what we consider when we think of as transplants, I don't think. There's then this thing, xenografting, which is where you take some tissue from one species and transplant it into another species. And probably the most commonplace example of that in medicine is the use of pig heart valves in transplant. And that's the reason for that is it's an anatomical size thing. So pigs have got hearts that are broadly similar in size and shape to humans. So it's just the best fit, if you like. I'm going to mention a little bit more about xenografting later on, because there's a kind of a good, if slightly controversial example of it that I'm going to talk about. And then at the bottom we've got allografting, and this is, I think, what we think of as being an organ transplant. So this is taking an organ from a non-identical member of the same species and transplanting it across. So that'd be me receiving a kidney from Simon. Okay. If in this context you're lucky enough to have an identical twin, then that's called an isograft. But obviously that's relatively unusual. So for most people, when we're talking about transplants, we're talking about allografting, which is taking an organ or some tissue from one person and putting it into someone else. So, as we said, if you include skin grafting, then some form of transplantation procedures have been ongoing since the 1860s. The next sort of thing was corneal grafting for eyes, which was sort of the early 20th century. But by and large, actually, what we think of as organ transplantation, the vast majority of important first procedures and a lot of the groundwork was laid down actually in a relatively short period of time, from the mid-1950s up until the kind of early to mid-1980s. And if you look across here, these are also first, so living related kidney transplant from a deceased donor, lung transplants, all these kinds of things, and these all happened in a relatively short space of time. And like most technological innovations, it doesn't matter whether it's in medicine, it could be in any other branch of science or what have you, along the way there's a few sort of important pioneers who took these things on and made them happen. So this gentleman here, he's a guy called James Hardy, and he was an American physician surgeon, and he was kind of an interesting character. He's very important, not necessarily for all the right reasons. So he did the first lung transplant, and of all the transplant procedures, lung transplantation is technically the most difficult. It's the most difficult operation. Not all transplant surgery is very complicated. So kidney transplants, it's probably no longer an operation to have a kidney transplant than it might be to have your gallbladder out. So it's actually quite a routine procedure in terms of the surgical technique. It's not too difficult. But lung transplant is difficult, and he was the first person to do it. And the patient survived, I think, probably for about a week, 10 days, something like that. But as was common at the time, the patient died very quickly as a result of infection. We're going to talk about infections in transplant patients in a little while. So he achieved a lot of sort of street cred for doing the first lung transplant, and then he blew it slightly. Because contrary to what is largely recognised in medical history, this man performed the first heart transplant. Okay? But he performed a xenograft heart transplant, and he transplanted into a human the heart of a chimpanzee. Okay, now this would be, I think, broadly speaking, controversial if you did it now. Okay, obviously at the time there'd been a lot of there were a lot of animal models used before human transplants. There was a lot of research done on animals, and that's the way it was. When he did this heart transplant, he didn't necessarily follow a recognised ethics pathway. And he landed, the hospital where he did it, landed in quite a lot of trouble for kind of not really keeping a close eye on him. And so actually, despite the fact that he was very, very important, he kind of blew his reputation. That's probably why we've never heard of him. Yeah? You probably have heard of this man. Christian Barnard, yeah? So Christian Barnard was the first person to do a proper heart transplant. So South African physician, surgeon, worked in Cape Town and led a team, a very pioneering team, which included his brother. And he did the first human-to-human heart transplant in 1967. And it was technically successful. It wasn't the same procedure that people have now. So it was slightly more complicated. So now if you have a heart transplant, your heart is kind of moved to make space. In this case it wasn't. It was a kind of an additional thing. But the patient survived for, I think, about 18 days. And again, unfortunately succumbed to an infection, which again we'll talk about in a moment. But he was very, very pioneering and really very rapidly moved heart transplantation on. So not only did he do the first heart transplant, but he was one of the first people that did multiple heart transplants. And within a very short space of time, he was becoming, or the patients that he was looking after were surviving for significant lengths of time. And by the time he'd been doing it, and he got up to about 18, 19 patients, the 18th and 19th patient went on to survive for years and years. So it was really, really very progressive. He also did one of the first ever kidney transplants. So again, largely recognised for heart transplants, but did lots of other stuff as well. And then this man, who I'm pretty sure nobody will ever have heard of either, is a guy called Thomas Starzl. And out of all of these people, including Christian Barnard, this man deserves really to be very, very well recognised. So he did the first liver transplant in 1967. He did the first heart liver transplant in a child in America in the early 1980s. So he was very innovative in terms of surgical techniques and things, but he did loads and loads of other stuff. So when we come on to talk about some of the drugs that are used in organ transplants, he established the use of those drugs. He ran the first trials of them. He did a lot of work around the ethics of transplantation, how you manage to get organs to survive for long enough to make them viable for transplantation. He did loads and loads of stuff. And probably without the work that he did, organ transplantation would probably be 20 years delayed. So he's an interesting man, Thomas Starzl. So, and he worked all the way up until he retired in the late 1990s. So he was practicing relatively recently. So although most of the stuff happened in this kind of 30 or so year period, clearly since then there have been lots and lots of things. So I think people have had a pop at transplanting virtually anything. And some of these things make sense, some I think are controversial. And there's huge amounts of ethics around things like facial transplants and all of this kind of stuff. And that's not to say they shouldn't happen. But I think that there's been lots of controversy. So in terms of all of this sort of the major solid organ transplantation, most of the progress was made a long time ago, although there's still lots of research ongoing, but really we're talking about innovating into other areas now. So the reason that transplants kind of became a viable option at the time when they did was not actually, we tend to think of transplants as being about the surgeon who does the operation, and of course the surgeon's an important person. But the reason transplants became viable when they did and subsequently became much more successful was, like lots of things, it was the sort of accumulation of knowledge, technology, within a whole range of disciplines. So it is about the surgeon, but it's about physiologists, physicians, immunologists, geneticists, there's all this stuff. And you've got to have all these bits in place to really allow you to successfully do the operation. And then of course you've got to have people like pharmacologists to help you with the medication, you've got to have psychologists to help people through the process. So really, the major innovations now around transplantation are really about multidisciplinary care, but none of this could have happened if you hadn't got all of these things coming together at the same time. So the surgical techniques that are used have been around for donkey's years, but it's about having all of it coming together at once. This is a slide which shows you the number of organ transplants undertaken each year in the UK from 2005 to 2021. Shows a couple of things that are relevant. So you can ignore 2021 for a multitude of reasons. But in terms of transplants, a lot of transplant lists were suspended. But if you ignore that, what you can see is there was a kind of general increase in the overall number of transplants pretty much year on year, really, up to around about 4,000 per year. That's just in the UK. So if you think about the fact that in terms of procedures, many of these operations, the first ones might have only happened 30, 40 years ago. To actually get to the point where just in the UK, you're having thousands per year shows how this has taken off. And remember, you know, that we've got a good transplant system within the UK, but it's equalled, if not bettered, across, you know, Western Europe, North America, Australia, New Zealand. So there are tens of thousands of transplants worldwide each year. So it really has taken off as a common procedure. So I don't see that many people that have had heart transplants coming in through sort of general clinical care. I see a few people, periodically see people with liver transplants. I see lots of people that have had kidney transplants. Kidney transplants are the most common, but I reckon I probably see one person every other week who's had a kidney transplant. You know, it's quite a common operation. This shows you, again, you can ignore the middle column, but this shows you how many people were on an active transplant list. It tells you what organs they were hoping to have a transplant for, but what you can see is there were about, at the time when there were 4,000 procedures being done, there were about 6,000 people on the waiting list. So there is always a divergence between the number of people waiting for an organ transplant and the number of people receiving one. And there's various reasons why that divergence doesn't keep getting bigger and bigger and bigger. But the two are that sometimes people get put onto a transplant list and then by some quirk of fate or good medical care, their condition gets better. So they can be pulled off the transplant list temporarily, sometimes permanently. It might be that something else happens to the person which actually then unfortunately disqualifies them from being able to have a transplant. Or it might be, and sadly this is the case quite often, is that unfortunately a proportion of people who are on the transplant list waiting for an organ will die whilst they're waiting. So it's those things really which stop the divergence from getting more and more. But the rate limiting step to all of this, as we're going to talk about a little bit later, is the availability of donor organs, which is the thing that really slows the process down. So how do you go from being ill to needing an organ transplant? Well, this is a very sort of simplistic slide really, but you have to go through these phases. So the person will develop failure of an organ or sometimes several organs. A few of those people or you would hope to get appropriate people from that point to getting their transplant assessment. There'll be some people who for a variety of reasons don't get to the transplant assessment. That might be because they're deemed not appropriate to go on the list, and we talk about what that means in a sec. I mean, some people who get through the assessment successfully and go onto the waiting list, a few people again won't, either because they become too unwell or something else happens. You go from the waiting list to the transplant procedure, and then the transplant procedure will end up with you having follow-up for an undetermined but hopefully significant length of time. So organ failure then, so The key to most of this is that most people who develop an organ failure, so a heart failure or kidney failure or something, it's usually a slow process. And what that allows is it allows people a bit of thinking time to get people into the system at the appropriate point. So it's usually developed slowly. It doesn't always. So there are some occasions where people will become very rapidly ill, require a transplant urgently and get one. It's relatively unusual. And it usually happens, it happens with children quite often for heart transplants. And in adults, it most commonly happens for liver transplants. And that's because of two real types of illness. One, viral hepatitis can sometimes cause your liver to fail very quickly. And the other one is there's a small percentage of people who take paracetamol overdoses, who damage their liver very severely, and the only treatment option available for them is a transplant. So I look after a lot of people every week who've taken paracetamol overdoses. Relatively few of them get transferred to the liver unit. We've managed to sort most people out. And out of the people that go to the liver unit, only a tiny proportion will need a liver transplant, but it is a recognised indication for having a transplant. But by and large, it's usually a controlled chronic process that allows people to have a planned approach. You've got to be under the care of an organ specialist. So I'm not an organ specialist, I'm not a kidney doctor or a heart doctor. I'm a jack of all trades. But you'd have to be under a kidney specialist, and that's for two reasons. One is so that they can make sure that the care of your underlying condition, your kidney problem, is as good as it can be. And there are a number of conditions that if you get the appropriate treatment, you can either, completely avert the need for a transplant, or you can completely reverse the disease process. So you need to be under an organ specialist so they can think about that. They also need to be able to optimise any other medical conditions that you might have that might be relevant. And of course, they will know the criteria at which you would qualify for a transplant. So everybody will be under an organ specialist. Okay. From there, so if you developed a problem with your kidneys here and you ended up under a kidney specialist at New Cross, for example, or at Russell's Hall, if you needed a transplant or if you were being considered for a transplant, they would then refer you to a specialist transplant centre, which for us here is at the Queen Elizabeth University Hospitals. They've got a liver transplant service there. And I think they do heart transplants as well. If not heart transplants, is somewhere like Papworth. So they don't. This is not stuff that's done everywhere. So depending on how you are and when you get to your transplant assessment, it's quite a complicated process. As you can imagine, there's a number of stages that you have to go through. They have to have a good understanding of what your specific illness is, where you are in that, in the spectrum of that illness, what other conditions you have. They have to know what medications you're on. They often do sort of psychological assessments of people. So it's a complex system, which is why it works better if it's done in a planned way, carefully. The criteria for having an organ transplant will depend on the organ you're having transplanted. So clearly, if it's your liver, there'll be specific markers. If it's your heart, there will be. This shows the kind of stuff they might go through if you need a kidney transplant. I can't remember which hospital it's from. It doesn't really matter. So there'll be a few broad points that the transplant team will go through. The top two. So this is the patient is on dialysis, or this bit here is not on dialysis but has a GFR less than or equal to 20. So these two things tell you that the person's kidney failure has got to a set point. So it's either so severe that they need dialysis treatment, or GFR is a measure of your kidney function. Normal GFR, for argument's sake, is say 100. The lower your GFR, the worse your kidney function is. So 20 would be your kidneys effectively functioning at about 20%. So there has to be some sort of criteria to say that actually your kidney disease is at such an advanced stage that this is a sensible option for you. So they make some judgments around that and determine on that basis whether you would be eligible for a transplant. They then go through these things really, which are, so they try and opt as many people into this, but then of course there are exclusion criteria, and they're either what we call absolute contraindications. So if you have one of these things, you are excluded from the transplant list. These relative ones are things that might get you excluded, although they may not be quite as concrete. There's a little bit of individual judgment. And these things will be common for all transplants, so the criteria, the cut-offs might be slightly different. But so for kidneys, there's an age bracket. You are excluded if you've got an active cancer. And the reason for that, you're going to find out a little bit later, is as soon as you put people on immunosuppressive medication, their risk of their cancer getting worse is significantly higher. And the other thing is, of course, that I mean, this is ultimately all about rationing. And so if somebody's gonna receive an organ, you want that person to get as many years out of that organ as possible. And if they've got another potentially life-limiting condition, you may determine that that's not a suitable use of the organ in basic terms. So cancer is a difficult area. If you've got significant HIV infection, and again that's all to do with your immune system and your long-term prognosis. So there's something about that. So there's conditions that exclude you, and then there's this one here about myocardial dysfunction. That's if your heart's no good. And of course that doesn't apply if you're having a heart transplant, because that would be the point. But if you're having a kidney transplant or a liver transplant, then you need to be able to get through the anaesthetic. Yes. So that's about the anaesthetic risk and the risk of being on critical care units and that sort of thing. If there's something about your psychological profile or your social support network that is going to be non-conducive to you being able to reliably take treatment. So if you're very chaotic, if you don't take your tablets, this is not going to go well. So there's that sort of thing. Alcohol and substance abuse. Alcohol in kidney transplants. So if you like, if you like a couple of pints and you need a kidney transplant, that's absolutely fine. If you like a couple of pints and you want a liver transplant, that's not. Okay. And to qualify for a liver transplant, you have to have been abstinent from alcohol for 6 months. And if you run it, when I showed you the 3 famous people at the start, I was going to put George Best on, and I thought, as it was a good news night, I thought I wouldn't. So alcohol use is, in most cases, allowable, as long as it's not excessive. And then if you've got very bad lung disease, which requires you to have oxygen therapy all the time, again, not if you're waiting for a lung transplant. And then there's these other bits and pieces down the bottom, which again are sort of, they're a bit woolly and open to interpretation, but these ones are definite no-nos. So that's the sort of thing that they're assessing people for when people go. The other important bit is about making sure the organs are compatible. And I did a talk, I don't know when it was, about genetics, and I've done one about immunology as well. So really what you want is you want because these people are not genetically identical, they don't have identical immune systems. So if one of you guys was kind enough to donate an organ to me, my body would recognise that as being a foreign invader. And so what we need to do is we need to make it as compatible as possible. I need as good a match as possible. And so they do that in broad terms by, the first thing is you have to have the same blood group by and large. They are kind of starting to do transplants with ABO incompatible people, but it requires really, really heavy immunosuppression. So you have to have very, very potent anti-rejection drugs, and as we're going to see, that poses a risk in itself. You can do ABO incompatible transfusions on very, very young children, because their immune system's not quite as developed, so you can kind of get away with it a bit there. And then there's this other bit which I'm not sure I fully understand really, but this is the bit of your genetics that really allows your body to recognise what's foreign to you and what's yours, if you like. And within your genome there are about 6 or 7 bits of your genetics which contribute to this. And the idea is that they would tissue type me and say, well, Phil's got, he's got these 7 HLA bits. Simon's offered him a kidney. He's got 7 that are very similar. It's a good match. Or it might be, oh, he's only got 1 that's very similar. That's not a very good match. And in that case, it might be more sensible that that organ is donated to someone else and I stay as I am. So it's about trying to get all these things matched up as much as possible. And all of that sort of stuff happens at your pre-transplant workup as well. The transplant procedure itself, as I said, the surgery itself obviously depends on the operation or the organ that you're having. So I was very privileged as a junior doctor. My surgical first year job, my house officer job, I worked for the renal transplant service in Coventry. And as I say, the operation itself is reasonably straightforward. There's a whole load of logistics around it when the organ arrives and people's pages going off and all that kind of stuff. It's very kind of ER, really. But it's a very simple operation, but it is absolutely amazing. So they take this kidney and they connect the blood supply up to it first. And so the kidney just looks very, like a kidney looks like a kidney. It's a sort of a deep red colour. But when it's not attached to anything, it just looks kind of creamy white. And then they connect the blood supply up to it, and it just sort of blushes. And then the ureter, which is the tube that connects your kidney to your bladder, that's obviously not plumbed in yet either. And so within 20-30 seconds, little bits of urine start coming out.
Wow.
It is absolutely amazing. I was like, yeah. So the procedure itself, I'm not going to talk too much about that, but I'm sure you can find some stuff on YouTube if you're so inclined. The complications of having a transplant, we split into the sort of the very immediate complications and then ones that come a little bit later, so the first month or so, and then ones that might occur after that. At all stages, there is a chance that the organ will get rejected, and I'll talk about that separately in a second. In the short term, the very immediate term, the things that go wrong are the things that could go wrong with any operation you had. So you could get a wound infection, you might get, hopefully you wouldn't, but you might get another bit of you damaged or something like that. So the things that you would be consented for if you had any operation. The other things that then happen, other than organ dysfunction, which I'll talk about separately, are we've already touched on the fact that you're very prone to getting infections, so we'll talk about those. And then we mentioned briefly as well about cancers, and I'll talk about those. But I just wanted to talk to you a little bit first about immunosuppression and organ rejection. So none of this would be possible if we weren't able to manipulate your immune system. So unless you've got an identical twin, the chances are nobody would be able to have an effective transplant. Because everybody, even if it's a really good match, everybody needs to have their immune system damped down slightly. So it's really, more than anything, it's the clever use and the clever manipulation of your immune system that allows any of this to be possible. And at all stages, so induction is the point where you start on immunotherapy, immune suppression, and that happens, so as they're plumbing the kidney in, they're giving you medication, or they might be giving you even before the operation has started, essentially to flatten your immune system, to give the organ a fighting chance. You then get a period of maintenance therapy for about the first month, and then hopefully over time, depending on how you're getting on, the idea is to have you on the least amount of immunosuppression that will allow your organ to be safe and also prevent you from being exposed to too many infections and other things, so it's a balancing act. And there's several classes of drugs, doesn't matter what they are, okay? But the point with them is, you might have heard of some of them. Most people probably heard of prednisolone. It's commonly prescribed for a lot of medical conditions. So there's several different groups. They all work in slightly different ways, so at different points in the immune system on the white blood cells and with antibody production. And the idea is, like everything, if you can go at something from a number of different angles, you get a better overall effect. So at all points in this process, from the first dose all the way through your maintenance treatment, you are always on a combination, usually of 3 of these drugs. And it's usually one of 3 from these top groups. They might substitute one of this grouping. So generally you're always on 3. The only thing that changes is the dose of individual drugs over time. And they will manipulate those depending on various things. These other drugs at the bottom, these what we call biologic agents, these are relatively new. They're sort of what we call monoclonal antibodies, and they're very, very potent. And they're used for, monoclonal antibodies as a drug group are used for loads and loads of things, rheumatoid conditions, inflammatory bowel diseases, all sorts of things. But in this context, they give you a boost of these drugs at the point of induction. These are very powerful, and they give you that, and they usually give you a high dose of steroids and wallop your immune system at the point of the operation. So that's basically how the immunosuppression works, or the theory behind it. At any point, we've already said, the organ unfortunately can get rejected. And mostly in the first 30 days or so, that is an immunologically mediated thing. So either you haven't got the immunosuppression quite right or something like that. Hyperacute rejection is a very, very florid immunological response. It's kind of like transfusing the wrong blood into someone. So it's an almost immediate, that kidney or organ is just going to fail. And that shouldn't happen if you've got the tissue typing right, and if you've really, really suppressed the immune system. Once it's happened, there's nothing you can do about it. It happens too quickly to be able to reverse. So that's all about the planning phase. The other thing is the acute rejection, which is in the first month or so. Again, that's usually immunologically mediated, and the easiest way to sort that out is to tweak the immunosuppression. And that probably, to a greater or lesser extent, happens in a lot of people, because obviously everyone's slightly different and you don't quite know how much treatment people are going to need. Chronic rejection might be to do with that, but often it's just to do with, I mean, it doesn't necessarily happen at 30 days, it might happen several years later, and so you know, that may just represent aging of that organ to a degree. So that's a little bit about rejection. Infections, so we've already said most of the early transplant patients died as a result of infection. And your immune system is really, really very heavily compromised when you have a transplant in the first month or so. If you get an infection straight away, again, it's usually the kind of infection that you might get if you had any sort of operation. There is cases reported of infections, and it's a bit unfortunately, but infections being transferred across with the transplant organ. Yeah, so that's why very careful screening and stuff happens. If so if you're going to be a living donor for someone, they would screen you for lots of infections and stuff first. Obviously, if an organ has come unexpectedly from someone that's died, it may not be possible to get all of those pre-transplant checks done in time for the organ to remain viable. So there is a small risk that that could happen. As you move on after that, in the first 6 months when your immunosuppression tends to be at its highest, you get a lot of the infections that are associated with having a very poor immune system. So lots of the infections that would occur with people with kind of advanced HIV or AIDS, so things like PCP and all these kinds of things. And then as you go on, people generally, by and large, become more prone to getting the sort of infections again that any of us could get, so chest infections, pneumonias. But there are one or two things like viral illnesses which might flare up later on as well. So infection is a problem, and if somebody comes in with an organ transplant who we think clearly has got an infection, it is very, very complicated to understand and sort out what the cause of that might be. Much more that, if somebody's got a normally functioning immune system, it's relatively easy, to be honest. But if somebody hasn't, there's so many things that could cause it that you have to keep a very broad mind. So we touched on cancer. So one of the things that's apparent when people have been followed up over a long time when they've had a transplant is that one of the things that happens much more commonly in people that have had transplants is that they go on to get cancers. If you have a transplant in for 20 years, about 40% of people will have some sort of cancer, as opposed to if you take a comparison group where it's about 6%. So it's a significant risk. Not necessarily cancers like lung cancer and those kinds of things, but they tend to fall into these three groups. So there's skin cancers, and these are usually linked to the longer you've had the transplant in, the more likely it is to happen. And they're treated in much the same way if people get, this is a squamous cell cancer of somebody's lip here, but most of the time, they can be operatively sorted out and they adjust people's immune suppression. So they're a constant problem, but they're more sort of a nuisance rather than something that's going to cause anybody any significant shortening of their life. Lymphoproliferative disease is conditions like lymphoma, and it's not clear, but obviously you're mucking around quite significantly with people's immune system, and what isn't fully understood is whether it's that process itself that kind of derails the immune system and then it overshoots and people get lymphomas, or whether it's due to some a specific medication that people get. People don't know. And then there's this condition, which is one shown here, which is Kaposi's sarcoma. And I can't remember whether I talked about Kaposi's sarcoma. When I did a talk previously about viruses and about HIV. And Kaposi's sarcoma, it is or was a very, very rare form of skin cancer. And it was rare until the 1980s. And then because of organ transplantation and because of AIDS, Kaposi's sarcoma became recognised as a condition which happens in people who've got very, very suppressed immune systems. And they think the thing that links all of these things together is that they're so potentially associated with a chronic viral illness, chronic viral infection. So when I was a medical student, I did a bit of research on Kaposi's sarcoma, and it's very, very closely linked to people having chronic infection with a member of the herpes virus family. And if you treat the virus, the Kaposi's sarcoma doesn't happen. And lots of lymphomas are associated with viruses, and so they think that might be the link. So there's those complications, and then people tend to be under follow-up, not just for these sorts of things, but also there are lots of metabolic complications. So the way in which your body processes sugars and fats and all sorts of things changes, and there's a whole range of things which tend to occur as a result of these types of problems. And clearly what you want to do is you want to minimise the effect of these things, because these things are directly related to organ failure, and heart disease and these kinds of things. So a lot of the work that happens in follow-up clinics is making sure that people's cholesterol is well managed, that their blood pressure is good, that they're not developing diabetes and these kinds of things. So, just to kind of wrap up then for the last couple of minutes, we've already touched on the fact that the main rate limiting step to a lot of this is organ donation. Organ donation and the law, legislation, are, as you can probably imagine, very closely intertwined. And the blunt end point of previous legislation around, not just around organ donation, but around other areas, meant that a lot of people were dying and continue to die because they don't get an organ in time. And historically, up until here, this time, the organ donation system in the UK was a presumed opt-out system. So unless you as an individual had a conversation with your family and they volunteered the information, or you carried a donor card, it was assumed that if people died or were in a position to donate organs after death, it was assumed that families wouldn't get approached because it was opt-in. And the problem with that was, of course, these are quite difficult conversations to have with people. If you've got somebody who's just very recently died, it's a very sensitive subject, so people were understandably sort of reluctant to have these conversations. And then there are other bits of legislation which are for the greater good, fantastic, but actually in terms of organ donation were very troublesome. And so things that you may not think about, like seatbelt legislation. So, a significant amount of organs historically were donated by people who've been fatally injured in road traffic accidents. And of course, cars are so much safer now, and seatbelt legislation, that again, that the pool of people from whom you might be able to get organs was too small. So this has been recognised for years and years, and it's one of these things that kept going round and round in circles, really. But there was a big head of steam built up behind it in sort of from about 2012 onwards, and eventually it got royal assent. Unfortunately, it's a very important piece of legislation, but it got royal assent in the middle of a global pandemic, so nobody knows this. Yeah? And this changed the law, and the law is now one of presumed opt-in. And although that doesn't oblige anybody to donate an organ, it doesn't oblige you as a family member to have to donate relatives' organs, it does give people a bit more oomph about coming to have the conversation if it's appropriate. So nobody knows, obviously we haven't been able to really fully understand the effect of this change in the law yet. Even without the pandemic, it would be too short a time frame for us to know really. So it's got it's legal jargon, isn't it? It's got a nice long-winded name, and it's colloquially known as Max and Kira's law. So this is Max, I don't know actually what his medical condition was, but he ended up at the point where he needed a heart transplant. And he became a very, very, he and his family became very vocal advocates for trying to change the law around organ donation. And he, was seen as a figurehead for this with his family. And he received a heart transplant. He received a heart that was donated by this little girl. So this is Kira. And Kira was unfortunately killed in a road traffic accident. And I can talk about all these sorts of things, but actually this is what Kira's dad said. So meeting Max and his family brought us some comfort. It was really helpful to see how powerful organ donation is. Kira lives on in Max and the other people she helped. So there's a couple of asides to this. So one of my colleagues at work, his granddaughter had a very severe heart disease when she was very tiny, and was very, very close to dying. And she successfully had a heart transplant and is absolutely fine now, which is good. So, in summary, thousands of people worldwide, if not just in the UK, who have significant disease which may be amenable to them having a transplant. Not everybody who has an organ failure is going to be able to have a transplant, but there are lots of people who might be able to. And if you can get a transplant, it really is life-changing for people. So if you take somebody who is on kidney dialysis, 4 to 5 hours of treatment every other day, you might be able to have it at home. Most people have to come to the hospital. It's really very, very difficult. So it's not a panacea, but it is a really, really effective treatment. It does carry a number of side effects, and we have to acknowledge that and support people through those. And hopefully the change to legislation might impact on the number of organs that are available for donation. This was on the slide at the beginning. I don't know if any of you have had the good fortune to end up in the emergency department at New Cross in the last 18 months, 2 years. But if you go there, outside the new main entrance, this is the sculpture that's there. And it's called the Gift of Life. And what it symbolises is this hand passing on this DNA to represent tissue onto someone else. So that's what it's all about. And it's a memorial to organ transplantation. That's it. There you go.
Well, thank you, Phil. I think you kind of had a good idea what to expect, and Phil, you certainly lived up to and exceeded expectations. So thank you very much indeed for that. Fascinating as always. Has anybody got any questions for Phil?
I saw a program recently where you can grow steaks so that meat in a laboratory condition. They're only doing it on a small scale at the moment. It's not such a big step to grow human organs.
No, yeah, so they are doing it. Yeah. So they are trying to grow kind of genetically developed organs. Yeah. So it's still very experimental, but there's a thing, so they started working on it with skin grafting, and there's a thing called the skin gun, which basically it does exactly that. It sprays a sort of matrix on, and then you genetically engineer cells to grow on it. So I think that probably not too far away.
Just needs a few cells to do.
Yeah, absolutely. Will be the technology to grow
organs.
Same
whether you tasted any good one.
Yeah, I don't think. Yeah, I saw a program about the steak. I don't think it does.
Brilliant. Thank you. Alan, you got one.
Yeah. My question actually is stimulated by that last picture of Kira and the young man. And I was thinking, how do transplanted organs behave in terms of their intrinsic age when they're donated, and do they grow with the person that they are donated into?
Okay, yeah, so, so for children, they will try to come up with a size match. So in answer to part of the question, once the organ is transplanted into a child, it will grow in the same way that their own organ would. The aging process in terms of how long the transplant will last depends on lots of other things, but organs will age at a slightly accelerated rate because of the medication and everything else. You can, in children, put in a larger heart if needs be, but you can't put a smaller one in because it won't be big enough to meet the physical requirements. So hearts are difficult. Livers are really interesting because obviously, you can, for every donor, you can undertake 2 kidney transplants. Historically, for everything else, you just kind of got one of everything. Livers, they will transplant sections of liver. They're starting to work on just giving half a liver because your liver is brilliant at regenerating and growing. So livers and things, they're now looking at put sort of partial transplantation and then supporting that organ to sort of grow and develop. But yeah, in terms of children, they will try and size match things, yeah.
So for adults, do they try and age match them as well?
No.
So if you've had a 60-year-old heart in a 40-year-old person, will that heart remain at 60 and age accordingly?
Yeah.
Can you have 2 transplants?
Yeah. So
you would have 2 hearts.
Yeah. So people will have multiple transplants. Yeah. So the only extra, I think there was an exclusion on the kidney thing that says if you've already had 3, you're not allowed a 4th. But yeah, people will, if people need to, they'll be retransplanted. Yeah.
So,
No, if they have the potential person who they're going to get donations from, you sometimes, I can't think what number they said, but the potential of how many different transplants you can get from a body. Is there a sort of a little tick list, or is that so long now? Or
no, so in terms of the sort of the classic operations that you can have, I think it's 9 or 11. So if something were to happen to me, I'm on the organ donor register, and at one time you could, when you registered as an organ donor, you could nominate which bits of you were happy to donate. I mean, I just ticked the whole lot really, but yes, I think it's either 9 or 11. So it's corneas, pancreas, kidneys, liver, heart, bone marrow. So there's a whole host of things. So yeah, the potential is that, as Kira did, I think there were multiple children that benefited from ultimately what is an awful thing. When and I only found this out as a result of talking to my colleague whose granddaughter had a transplant, but his granddaughter had a transplant, but the family are embargoed from telling anyone for I think it's for a month, because and that's to protect the donor family, because obviously people say, well, that little girl's just had an organ transplant and that little boy died in a road traffic accident, maybe there's some sort of link. So it's all dealt with very sort of sensitively and very carefully. But I think that my colleague's granddaughter's family, her parents, have spoken to the family of the child that donated the heart. So yeah, it's very, very sensitively done thing.
Talking about that, one of our friends died very suddenly, and multiple organs were used. Just it was a year before the pandemic, and actually, our friend, the wife, received the most amazing letters.
Yeah.
Didn't say the names, but actually the interesting was that the age was quite similar. It
Yeah.
was also people that were in their 60s and have been waiting for several years.
Yeah.
And then they use this, the forget-me-not is
Right.
the
Yeah.
logo. And she treasures this box which have got all the letters in.
It must be very, I mean, it's just some form of consolation,
Yeah.
isn't it? I think to know that that's happened.
Mm.
Yeah. I think the whole thing around organ donation has it's been kind of I don't think professionalised is the right word, but ultimately at one time it used to be the remit of the medical team to think, this person might be a suitable organ donor, and actually you need somebody with a special sort of empathy and skill set to do it. So it's much more dealt with through specialist nursing teams and transplant coordinators and stuff now. So our role would be to identify that there may be someone suitable. Everything beyond that is done by kind of a third party. And I think that sort of makes it a bit easier because that person has the expertise, but also they're not immediately linked with everything that's going on. And I think you need that little bit of distance maybe from what's going on.
And presumed consent must have made a massive difference. And
I think
perhaps
it has, yeah. I mean,
an age difference as well. I wonder if, like the youngsters coming through now,
yeah,
almost expect that's what you do. I noticed just the other day that it's on the NHS app now that you can
yeah.
you can say which bits you want to donate.
Yeah.
It's just on the app, so
Yeah.
it's there and live immediately. And I wonder if it's a change of generation that just accept well, that's
think,
kind of what's happening.
yeah, I think it will. It will be a change in mindset.
Yeah.
With everything that's happened and the fact that the law's only changed recently, it's probably too early to know. But hopefully it'll make a big difference. It'll make a big difference.
Sorry.
Cool.
The anti-rejection drugs, do
Yeah.
they have to be on those for life?
Yeah, pretty much. Yeah. So then people may get tapered down, so they're only on relatively small doses. But yeah, it's a lifetime
And they
commitment.
still have to have them for a cornea transplant, do they?
So corneal transplants, not as much.
Right.
So for corneal transplants, you have to have lots of local immunosuppression to start off with, so lots of steroid drops and that kind of stuff. But I don't think you have to have full system-wide immunosuppression. And not all organs are the same. So relative to having a liver transplant, the amount of immunosuppression you need for a kidney transplant is less, for example. So some organs are more likely to cause problems than others.
It's all right, my daughter needs a cornea transplant,
Yeah,
but because of her special needs, they're not prepared to do it
yeah,
unless her other arc, she's got, is it cameo-type, where it goes into a cone shape.
yeah, okay.
But they said they'll only do an operation of if the other one goes the same.
Right, okay, yeah.
So she's got no sight in the one eye now, just
Yeah.
in the other. And because of the way she is, they said she wouldn't cope with the operation yet.
Right,
Because
okay.
she wouldn't cope with people putting drops in her eyes.
Yeah.
No.
So I think for corneal transplants, it's mainly topical, mainly drops. I
Thank
think.
you.
Are we looking at other options, other ways of getting organs? For example, rather than just cloning, are they still looking at making artificial hearts? So now I've read quite a bit of
Yeah.
those,
So.
quite interesting.
Yeah, so I think there's been, so hearts are a good example. So there have been loads of attempts at coming up with artificial hearts, and I mean, out of all of these things, the heart is probably the easiest one to do something like that with, because I'm sure cardiologists would disagree with me, but it's ultimately the most simple one. It's a pump. And so the sort of the left ventricular assist device, like Dick Cheney had, it's not inconceivable that actually you could come up with a process that replicates that for all of the heart. And I mean, you know, obviously kidney dialysis is a form of artificial kidney. Obviously, it's too big. It's the same for, so there's a treatment that you can have, which is sort of like an intensive care plus treatment called ECMO, which basically takes over the function of your heart and lungs for a period of time. So it's kind of like a fancy ventilator with a cardiac bypass machine, so the sort of thing they use when you have bypass graft. But the problem is that the scale for all of these things is too much. So I think hearts they are, in terms of the other things, because they're sort of physiological rather than mechanical, I don't think it's likely to be a sort of a...
looking through cloning, aren't they?
Yeah.
In terms of when you are a donor and something happens to you and obviously you want to take the organs, do they look into your medical history to see which bits might be no good?
Yeah, they will do, yes. So there are, in the same way there are things that will disqualify you from going onto the transplant list, there are things that will disqualify you from being a donor. Again, if you've sort of got, you know, disseminated infection of some sort, so TB or HIV, if you've got very advanced malignancy, those sorts of things. And that tends to be why the majority of solid organ transplants tend to come from people who've had, you know, a sudden cardiac event or an accident or something like that. But even if you have some sort of underlying pathology that would say stop you from donating your kidneys, or you know, there are still things like corneas, for example, you're still eligible to donate those. So it's quite complicated, but yeah, there will be things that about people that mean that certain organs can't be used.
Would age eliminate you if you're older from being a donor?
Not directly. Again, it might be similar. Obviously, depends on what your medical background is. You know, you could be 40 and be very unwell, or you could be 70, 80 and have very well functioning kidneys, and you know, your liver, for example, doesn't age much at all. So you're, you know, all things being equal, your liver function when you are 85, 90 years old is pretty much the same as it is when you're 20. So other organs, your kidneys tend to age more, so it depends a little bit on that really. So it's kind of individualised really.
Under normal living conditions, how long does it take to replace the liver? Because you do replace the organs all the time, don't you?
Yeah, so your liver sort of it's a bit unique. So for example, kidney damage. If you damage your kidney's not very good at repairing itself. Your liver function is, you could have you know, say a viral illness or paracetamol toxicity or something, which almost completely knackers your liver. But if you were supported with appropriate care through that, your liver function will probably recover in the space of a couple of weeks. So your liver's very, very resilient.
Because there's always cell replacement going on.
Yeah. There is, and it's just more effective in certain bits of you than others. So your liver is, you know, you can lose you can have half your liver taken out and it wouldn't materially affect how your liver functions. But you know, some organs will recover very, very quickly.
And I guess with immunosuppressant drugs that you were talking about there, how long have they been in for? 60 years? 70 years? Something like that? So I guess that, I was just thinking, really what we're trying to do is to fight against 4 million years, 5 million years of immunosuppression. Aren't we? And at a very early stage of doing that, and when you look at how it's advanced so quickly in such a short space of time, it almost seems the mechanics of it are sorted, now it's the genetics and the science of it.
And that's the same for so monoclonal antibodies.
Yeah.
Monoclonal antibodies as a therapy didn't exist 10 years ago.
Yeah.
Now, if you or if anybody you know has got rheumatoid arthritis, for example, all of the long-term complications that we used to see with people's joints getting deformed, that won't exist in 20 years' time, because everybody's just on these new treatments, and it's totally revolutionised. And other conditions, some cancers, so malignant melanoma, the skin cancer. When I was a junior doctor, if somebody came in with malignant melanoma, they probably were going to survive for a few months. Now it's a chronic disease. You can survive for 15, 20 years with melanoma. The treatment is so good. So, what this looks like now, in 20 years' time, it will probably be totally different.
It really is a good news story, isn't it?
Yeah, absolutely.
It really is, isn't it? Which is absolutely.
Of all the things I've talked about, this is the
This
one
is the
that
one
leaves
that-
with a rosy glow.
That's right. Has anybody got any other questions for Phil before we let him go? Because he's been talking for a while now. He's entertained us again. You've increased our knowledge. I don't know how much, Phil. Once again, and it's always a pleasure for you for us to hear you speak here. So thank you again. Thank you for being our first speaker of semi-normal life. We look forward to seeing you again, perhaps next month or the month after, sitting out there. And if you come back and talk to us again, that would be
I'm happy to come any time.
Thank you so much, Phil, and let's show our appreciation. Right, well, thank you. It's been wonderful to see you all. As I say, we don't know what's going on next month yet, so bear with us. Check your emails and we will let you know. Whether it's face-to-face, whether it's online, whatever we do, we will let you know. Thank you for tonight, and look forward to seeing you again soon. And